Good afternoon. Welcome to part 4 of our Coming Together for the Cure series to promote breast health and awareness. My name is Umber Dickerson. I'm the director of the cancer program here at Parkland Hospital, and we are so excited to have you here today. We will be recording today's presentation, so if you missed any of the previous series or want to rewatch today's session, you'll be able to see the entire series on both Parkland's Facebook and YouTube accounts. We encourage you to submit any questions you may have throughout the presentation on our WebEx chat function. We'll be answering your questions during the Q&A session at the end of today's presentation. Let me introduce you to our 3 panelists today. They are the 2 in the room which are socially distanced, and then 1 who is virtually with us today. First, we have Julie Dredden. Julie has worked at Parkland Hospital for over 23 years. She completed her bachelor's degree at the University of Texas at Arlington Masters and Doctor of Nursing Practice degree at Texas Women's University. She currently works at Parkland Medical Oncology Breast Cancer Team, assisting and treating patients who are high risk for breast cancer, as well as those with benign and malignant breast conditions. Michelle Hubner. Michelle Hubner is a graduate of Weill Medical College of Cornell University, Physician Assistant Program in New York City. She has been a surgical PA for over 15 years and joined Parkland in 2016. She is very excited to be part of this breast surgery team and participate in the care of cancer patients from all over Dallas County. And then we have Dr. Jody Hayes. Dr. Jody Hayes is a diagnostic radiologist for breast imaging division at UT Southwestern Medical Center. She obtained her undergraduate degree in nursing at Texas Health Science Center and her medical degree from University of Texas Health Center in Houston. She completed her diagnostic radiology residency, neuroradiology fellowship, and a breast imaging fellowship at Western Pennsylvania Allegheny General Hospital Consortium. At UT Southwestern, she serves as the Assistant Program Director for the Breast Imaging Fellowship, as well as Medical School and Residency Ambassador for Breast Imaging. Her research interests are centered around breast health in young women and disparity of breast health in underserved population. I'm going to kick it off now to Julie to start our presentations.
So I'm just going to go over really quickly the virtual meeting guidelines. If you don't mind just muting yourself when you join. The comments and questions should be typed in the WebEx chat function, and then questions or comments will be monitored. Okay, and we'd just like to thank you for allowing us to speak to you today. I know that the discussion that we developed to present to you today, we kind of got this from common questions that we get in our practice and things that we see that are trends through our practice every day. We're going to start just quickly by going over just the basics about cancer, and two of the very common questions that I get often is, how did I get breast cancer? Did I do something to cause my breast cancer? What made this happen to me? And really, no, you didn't do anything that caused your breast cancer, and we don't know what causes breast cancer most of the time. Most of the time, it is not genetically caused or genetically related, so we don't know the actual cause. We do know that cells start to divide rapidly. Cancer cells don't have a shutoff mechanism, so they just continue to divide, and eventually they form an area where you can hopefully early detect them, or they can be detected early on mammography or some type of imaging if you're going to get your mammograms done every year. Also, eventually they may become a mass that you can feel or your provider feels, and then can refer you to wherever you need to go. So breast cancer is commonly located in 2 places. Most of the time, breast cancer starts in the ducts of the breast and then also in the lobules, but most of the time you'll see the breast cancer starting in the ducts. In the lobules of the breast is where milk is made, and then milk travels down through the ducts and then out the nipple. So 1 in 8 women will be diagnosed with breast cancer in their lifetime, so around 13%. As one gets older, as women get older, the likelihood of breast cancer increases. We see breast cancer more commonly in Caucasian women. However, African American women have a higher death rate from breast cancer. And we think this could be related to problems with access to care or issues with the actual biology of the tumor and their tumors being maybe a little more aggressive. So this is the 5 to 10% of breast cancer that we know why it's caused. Only 5 to 10% of breast cancer is genetically inherited, so related to a familial cause. And you can see here the most common genes that we hear about are the BRCA1 and BRCA2 gene. There are other genes that are related to breast cancer or an increased risk to breast cancer, but these are the two that we see most commonly. As I said earlier, a usual woman without any type of risk factors has about a 13% risk of getting breast cancer in their lifetime. You can see here a patient with BRCA1 mutation has a 55 to 65% risk of developing a breast cancer. So that's significantly higher than the average female. With the BRCA2 mutation, it's a little bit less. It's about 45%. And then these mutations also carry an increased risk of developing ovarian cancer. So for the average population in a woman, usually their risk of getting an ovarian cancer is about 1.3%. So you can see here in a BRCA1 mutated patient, it's up to 44%. So again, a significantly higher risk. And then in BRCA2 patients, it's 17%. We do send patients for genetic testing and genetic counseling. Here at Parkland, we have an excellent genetic counseling service. Our genetic counselors, I think, are the best. So the patients that we send to them are usually the patients that you see here, people who get breast cancer before the age of 50, because like I said earlier, as patients get older, the risk of breast cancer is higher. So if you get a breast cancer before the age of 50, we feel like that's kind of an early onset of breast cancer, and potentially this could be caused by a genetic mutation. If a patient has bilateral breast cancer or cancers in both breasts, then we feel like they should be sent. If you have a woman that has breast and ovarian cancers themselves or in their familial line, if another family member also has breast and ovarian cancer, any patients that have a male breast cancer in the family, male breast cancer is common in BRCA2 mutated patients. If they are an Ashkenazi Jewish heritage, or if 2 or more BRCA-related cancers are within that family. So their BRCA1 related cancers are more like breast, ovary. We see pancreas cancers that could be related to a BRCA gene, also fallopian tube cancers. With the, I apologize if I said BRCA2, it's BRCA1. For BRCA2 patients, you see breast and ovarian cancer, and then you also see some prostate cancers. You can see melanoma, and then you also see the more male-associated breast cancers. So other risk factors that put a woman at an increased risk of developing breast cancer are family history. So if you have a first-degree relative with breast cancer, so a parent, a child, or a sibling. Again, if you have a personal history of cancer yourself, breast cancer. The next two, I just put abbreviations on there, but DCIS is ductal carcinoma in situ, and LCIS is lobular carcinoma in situ. Ductal carcinoma in situ is basically, we consider that kind of a stage 0 cancer. That's where the cancer is only isolated within the duct. It hasn't broken out of the duct or gone anywhere else within the breast. Lobular carcinoma in situ is not considered a cancer. It does put a patient at high risk for cancer. Sometimes it can, when it's excised from the breast or when it's surgically removed, it can hide cancers. So that does put a patient at increased risk. The next two are atypical ductal hyperplasia and atypical lobular hyperplasia. So these are just kind of cells that have started to look abnormal within the ducts or within the lobules. This is not cancer, but it can put a person at increased risk. And then, like I said earlier, if a patient has a family member, a male family member that has breast cancer, if there's any Ashkenazi Jewish heritage within the family, again, the BRCA-related cancers within the family, prostate, melanoma, those types of cancers. Patients with high breast density may be more likely to get a breast cancer. And then patients who go through early menarche or start your periods early, or late menopause, stopping your periods late. So that means that as long as a woman is menstruating, their body is experiencing increased levels of estrogen. Increased levels of estrogen can place you at an increased risk for breast cancer. So the earlier you start menstruating and the later you stop menstruating, the longer your body is exposed to estrogen. So there are some behaviors that can cause, we feel like they can put you at an increased risk for breast cancer, and there are some modifications to behavior that can help decrease your risk for breast cancer. So smoking, tobacco products, vaping, alcohol use, all of these can cause cancer. We don't know exactly the statistics for that. I do have patients that ask me, can I have a beer? Can I have a drink of wine? I think that's okay as long as it's done in moderation. I know moderation is a very broad term, but just, drinking every single day is probably not a good idea. One drink a week, I think, if you're celebrating something, I do think that's fine. You also have to be careful. Some medications that we give to patients who are at high risk or have had a history of breast cancer can affect the liver. So those patients also need to be careful with their alcohol intake. And then obesity also can put a patient at increased risk. Because fat cells can produce estrogen, the more fat cells in your body, then the more estrogen you probably have on board. Soy can also mimic estrogen sometimes, so we do say sometimes your diet should be kind of less soy based, so be careful with things like edamame that has a lot of soy in it. There are soy based milks, things like tofu. You just have to be careful with that. Again, everything in moderation. Of course, fruits and vegetables, lean meats are also very important to intake. And then exercise. Exercise helps almost everything if you're physically able to do it. So it does decrease the risk for breast cancer, and it's just a good habit to get into. It's good for your heart. It decreases hopefully your fat that you have within your body, and it's just a good healthy lifestyle.
So how do we screen for breast cancer? Well, the American Society of Breast Surgeons recommends that women over the age of 25 undergo formal risk assessment for breast cancer. And this can be done by a breast physician or other appropriate healthcare provider. And the majority of women are going to fall into the category of average risk. And so for these women, we recommend annual screening mammography, 3D preferred, and starting at the age of 40. And for women with increased breast density, we can consider supplemental imaging, typically with an MRI of the breast. But this is something that you should discuss with your physician. So high-risk screening, this is for women who are carriers of a genetic mutation, like the BRCA mutation that Julie spoke about, or who have a predicted lifetime risk of greater than 20% by any of the risk assessment models, or those individuals who have a strong family history of breast cancer or ovarian cancer. Additionally, individuals who have a prior history of chest wall radiation between the ages of 10 and 30. So for these women, we recommend breast self-awareness. And this is where we ask women to be familiar with their breasts in terms of how they look and feel, and promptly report any changes of their breast to their healthcare provider. We also recommend clinical breast exam every 6 to 12 months, as well as an annual screening mammogram. Supplemental imaging should be offered, and an MRI is the preferred modality. And we typically alternate mammogram and MRI every 6 months. The age at which to start this screening is really based on risk. And Dr. Hayes may get into some of this more in her talk as well. So women often ask, oh, when can I stop getting mammograms? And we typically recommend that as long as you're in good health and have a life expectancy greater than 10 years, you can continue to get mammograms.
All right. So there are some medications that you can take to reduce your risk of breast cancer. Of course, these are prescribed by a physician, and only after you've been evaluated. Usually in our practice, we see patients who have the like we discussed earlier, the lobular carcinoma in situ, the atypical ductal hyperplasia, the atypical lobular hyperplasia. We see those patients in clinic. Also, patients who have a strong family history of breast cancer. We can use a model. There are several models. We usually use what's called the Gale model. We use the patient's history. There are certain parts of a patient's history that we plug into this Gale model. And the Gale model gives us a 5-year risk and a lifetime risk. So it kind of helps assess the patient's actual risk for developing breast cancer in that time. The cutoff we use for prescribing medications, risk-reducing medications, is a 5-year risk of 1.66 or greater. And that's not something that you need to know, but that's something that your provider would look at when they perform this model. The Gale model is not used for women who have breast cancer already or who have a BRCA mutation. But we can, once we get this evaluation, then we can talk to you about medications that are offered. There are medications called SERMs, which are selective estrogen receptor modulators, and then there are aromatase inhibitors. And basically what these two classes of drugs do is, in a process in the body, they decrease the available estrogen. They do it in different ways, but that's what their goal is. So, and of course, all medications have side effects, so your physician or your provider would talk to you about these if you were eligible to have them. There are blood monitoring that goes along with these. Sometimes we have to do imaging of the bones for certain medications. So this is an option as a risk reduction method. The bottom part of the slide here talks about, these are just examples of other breast cancer risk models to assess breast cancer risk. Usually our genetic counselors do these, use these tools. I do not, but they can be used in patients that do have breast cancer, so that can assess their future risk. And like Michelle said earlier, they can get the statistic or the percentage risk of having breast cancer in their life. And if it's 20% or greater, then that patient would qualify for high-risk screening, which, as she discussed, is mammograms alternating with MRIs.
So in addition to medications, one other option for risk reduction is surgery. And so we consider this for patients in the high-risk category who have a genetic mutation, such as the BRCA mutation, or a very strong family history, and possibly for those with a prior chest wall radiation. And things to consider prior to risk-reducing surgery are the family history, as well as age and life expectancy. You should discuss with your surgeon the degree of protection that you would get from having the surgery, as well as your degree of cancer risk, as this is a fairly significant step in trying to reduce your risk of developing breast cancer. So the main surgery for risk reduction is a prophylactic or preventive mastectomy. And this is surgery to remove one or both breasts. The other surgery, which is less commonly done for breast cancer specifically, is a prophylactic or preventive oophorectomy. And this is surgery to remove the ovaries. It's often done with removing the fallopian tubes as well. But this is typically only done in women who carry the BRCA mutation, and it's not done for women who simply have a strong family history or other types of high-risk features. So how effective are these surgeries? Having a mastectomy actually reduces your risk of breast cancer by about 95% if you carry one of these BRCA mutations. And if you have a strong family history of breast cancer, it will reduce your risk by about 90%. So it's important to remember that it doesn't reduce your risk to zero. The preventive oophorectomy reduces the risk of breast cancer by up to 50%, although there is some debate about this, but there are some institutions that will state this reduction in breast cancer risk for those BRCA patients. We do know that it does have a significant reduction in the risk of ovarian cancer. So many women ask if they can have risk-reducing surgery if they've already had breast cancer, and the answer is yes. And this is known as a contralateral prophylactic mastectomy. And this can be performed at the same time as their breast cancer surgery, but oftentimes it may be delayed at a future date, and that's due to having needing to finish their breast cancer treatment. And so this is something to discuss with your breast surgeon as to what the appropriate time for having that prophylactic mastectomy would be. So with preventive mastectomy, about 95% of the tissue is removed. So again, this is why we don't get a reduction down to zero in terms of risk, because we can't actually remove all of the breast tissue. Surgery time is anywhere from about 1 to 3 hours, and this variation is due to either removing one or both breasts, and whether or not someone has reconstructive surgery. In addition, the size of the breast may change the length of time of surgery. And typically patients will spend one night in the hospital, but they may go home the same day, depending upon how well they do. Recovery time is about 4 to 6 weeks, and typically this means no strenuous activity or heavy lifting. Typically, you would be able to do most of your activities of daily living and be walking around and doing, dressing yourself and making meals for yourself as well. Now, there is an option of what is called a nipple-sparing mastectomy, and this is where the surgeon will leave the nipple and the areola. However, this is something to be discussed with your surgeon as to whether or not you would be a good candidate. There are some things to consider with this type of surgery, in that less breast tissue is removed, so your level of risk reduction is also less. So it may not be something that would be the greatest benefit depending upon your level of risk. So here's a list of the risks of surgery, and as you can see, there are some significant risks, which is why you need to weigh out the benefits of the surgery with these risks. But most women find that if they are high risk, the reduction in the risk, as well as the reduction in anxiety and stress, of potentially developing breast cancer is worth the potential risks of surgery. So bleeding, infection, pain. Most women want to know the level of pain that they're going to have after surgery, and many will express that it is much less than anticipated, particularly because we are not removing the lymph nodes that is associated with breast cancer surgery itself. And typically, if we don't do reconstructive surgery, then the pain is typically well controlled. Scar tissue and shoulder pain and stiffness is often helped with physical therapy. And numbness, this can be permanent or temporary. Seroma, this is a collection of fluid that occurs underneath the skin around the incision. And this is usually absorbed by the body. However, sometimes we do need to drain this in the clinic. Hematoma, that's a collection of blood, very similar to a seroma. And often this does not need any sort of other intervention and often will resolve on its own. Loss of normal breast functions, such as breastfeeding or sexual function. And this is particularly important for the younger women of childbearing age. And certainly there's psychological impacts in terms of change in body image and impact to sexual relationships. So these are all things that do need to be discussed when you're considering this type of surgery. And of course, it is irreversible. So many patients ask if they need to have reconstructive surgery after a prophylactic mastectomy. And the answer is no. It is entirely optional. You can see here in picture A that the woman had a bilateral mastectomy or double mastectomy where both her breasts were removed and she is flat. And a woman can remain that way, or she can have reconstructive surgery. And there are two options. One is with implants. They can be either saline or silicone. And the other option is autologous reconstruction. And this is where we use your own tissue to recreate a breast. Typically, this tissue is taken from the lower abdomen, but it can be taken from other areas of the body. We usually use skin or fat, but sometimes muscle is used. The surgeons can also use a combination of implants or your own tissue. And you can see a picture of that here in the second photograph. And this woman had autologous reconstruction with nipple tattooing. And the surgery can be done either immediate or delayed. Immediate, they do the reconstruction at the time of the mastectomy. If it's delayed, that could be months or years later. And the decision to do that is really, either a personal one or dependent on the patient's health history. So if reconstructive surgery is considered, then you would be referred to a plastic surgeon to go over your options and see if you are a candidate for this type of surgery. One contraindication to reconstruction is smoking, as this can impact healing and lead to a very poor outcome. The other issue that would delay potential reconstruction is a history of diabetes that is poorly controlled. So if a woman chooses not to undergo reconstructive surgery, she can choose to wear a prosthesis. And there's some examples here. This is a device that can be placed inside the bra to fill out clothing. And this can typically be ordered by the breast surgeon. We have a wonderful resource here at Parkland that allows women to obtain prosthesis. And they get fitted for this several weeks after surgery. and it allows it to be symmetric and allows them to have something underneath their clothing. So there are a lot of websites and organizations that offer breast cancer support. One of them is American Cancer Society, and they have several different websites. One is the Reach to Recovery. This is where volunteers provide support through online chat or by phone, and that can be accessed at reach.cancer.org. Another one is a survivor network, where online members connect through chat rooms and discussion boards, and that's primarily for members to discuss tips on things that have helped them through their treatments, and that's can be accessed at csn.cancer.org. And then they also have a survivorship guide, which offers tools for cancer survivors and caregivers, and that is at cancer.org/survivorship guide. So we just want to thank you for your time.
And then Dr. Hayes is going to present her portion.
Hi, are y'all able to hear me okay?
Yes.
Perfect. First, I want to thank Umber and the organizers for inviting me to come and speak today. What I wanted to discuss was common myths that we hear quite often in our clinic and get some facts and some open conversation going. Next slide. Probably one of the most common myths that we hear all the time is that only women with a family history will get breast cancer. As we've kind of already discussed, that is absolutely not true. Next slide. The fact is that 70% of breast cancer patients actually have no risk factors at all, and that includes a family history. As they went over, there are several different risk factors that can put you at an increased risk for cancer, but still it is important to understand that 70% of patients, there are no identifiable risk factors. If you do have a family history of breast cancer, one first-degree relative will increase your risk by 2 times. If you have 2 or more first-degree relatives, that will increase your risk by 5 times. Family relatives that are a little bit more distant, aunts, grandmothers, great-grandmothers, cousins, all of those will increase your risk just a little bit. But if we see multiple family members, especially on one side of the family, that can alert us that there may be a health gene that's in the family, a gene that has been altered, and we can get you genetic testing. Next slide. Another myth we hear often is that young women don't get breast cancer. Next slide. The fact is that all women are at risk of breast cancer. It's true that women over the age of 40 have a slightly higher risk of breast cancer, which is why we have decided to start screening at 40. That is the best time to start screening based off everything that we've seen in the research. 7 out of 10 cases of breast cancer are diagnosed in women 55 years of age and older, but there is still 5% of breast cancer that occurs in women below the age of 40. That's very important to understand because that is below when we will screen. So we typically don't screen women below the age of 40 because overall the risk is very low unless they have a family history or a known altered gene or some high risk factors. But women at this age, below 40, still need to make sure they're talking with their family physicians around the age of 25 and getting a formal assessment to understand their risk and when the most appropriate time is to screen. That's also a very good time to start doing monthly breast exams. We recommend a week after the menstrual cycle so that you can have a constant feel of what your breasts are so that you're alerted to the first time there's any change. Next slide. Another myth that we do hear still is that men don't get breast cancer. Next slide. The fact is 1% of breast cancer does occur in men. In 2019, 2,670 US men were diagnosed with breast cancer, and in 2019, 500 of them died. Men typically do carry a little bit of a higher mortality rate than women, simply because there's less awareness. They are not the population that we tend to screen. And there's a little bit of a delay in treatment, often because there is denial or because people just don't truly understand that men are at risk of breast cancer. So it is important that men do understand that there is a chance of breast cancer still, and that if they feel something, it's always safer to let your doctor know so we can check it out. Next slide. Another myth that we do hear is that women can't get breast cancer when they're pregnant. Next slide. Sadly, this is very untrue. Breast cancer is the most common cancer that we diagnose in a pregnant woman or in a new mother. Often these women are young, they're at very low risk for cancer. It's a high hormone state, and some breast cancers are hormone receptor positive. So this is a dangerous time for breast cancer. It's also a confusing time for women because their breasts are undergoing lots of significant changes. So there's lots of pain, there's lots of new feelings that are abnormal, especially if it's your first child. So just keep an open conversation with your doctor. We're always happy to see you in the clinic if there's any concerns, and we can do exams to put your mind at ease or to get a diagnosis. Next slide. Breast cancer always forms a lump. That is a myth. Next slide. Although breast cancer can absolutely form a lump, a lot of lumps that we see in the breast center are actually benign. There are about 8 signs of breast cancer that you should be watching for. One of them is a textural change in your skin. Your skin gets kind of a thickened orange peel type texture. You can have dimpling or a retraction of your skin. If you have clear or bloody nipple discharge that comes out all on its own, especially if it's on one side, that can be a sign of something abnormal. Redness or a rash on one breast or a rash on the nipple. Those are things we need to look at. You can have a lump not only in the breast, but also in the armpit, and we need to make sure we're looking for those things. And then if the nipple pulls into the breast, if that is a new change for you, your nipple is pulling back and you can't get it to pop back out, that is a sign that there could be something abnormal going on and we need to take a look. Next slide. Myth that we hear sometimes is that wearing an underwire bra can cause breast cancer. Next slide. There is no scientific proof that bras of any kind cause breast cancer. Just because your bra is painful or because your bra is rubbing you in certain areas, that is not going to cause harm or cause cancer. It is good to go get a well-fitted bra and to change your bras every 6 months as the spandex and the contraction parts of the bra relax a little bit. That will actually decrease your breast pain. If your breasts are held in a better position, the ligaments aren't stretched, there's not as much motion in your breast, then you actually have less breast pain. It can be a more comfortable experience. So we do advocate wearing bras. It's also good to help the breast not droop as much when you get older. Next slide. This is new and interesting. So putting a cell phone in your bra can cause breast cancer. Next slide. That there has been no scientific proof that a cell phone can cause breast cancer. So if you feel the need to stash your cell phone in your bra, you can do it if you want to. There are definitely other alternatives. I would not advocating put a ton of stuff in your bra because you can cause some trauma to your breast. I definitely would not go for the candy in the bra. But if you do need to put your cell phone in the bra, or if you're carrying your cell phone close around your chest, don't worry. It's actually not causing any cancer. Next slide. This myth we do hear a lot, that deodorant or antiperspirants can cause breast cancer. Next slide. There has been absolutely no link between deodorant use, antiperspirant use, and breast cancer. There are several preservatives, several different compounds that are put into deodorants and antiperspirants, and a lot of times you will see news reports that they're toxins and that people are finding lumps in the armpits or lumps in the upper outer breast, and it's all from the deodorant. That has never been proven. There has never been a cause and effect relationship. You are welcome to wear your deodorant and your antiperspirant. We don't want you wearing it to the breast center simply because we can actually see it on the mammograms, and sometimes it can confuse the picture. So if you wear it to the breast center to have your imaging done, we will take it off. But you can bring it in your purse and put it on if you want to, and it does not offend us if you don't have it on. So wear it if you want to, but don't worry about it. Next slide. And another myth we hear is that women of color are more likely to get breast cancer. Next slide. And the clinicians earlier touched a bit on this. White women are actually more often diagnosed with breast cancer, but we do know from a lot of research that our African American population is more likely to die from breast cancer. In the bottom of this slide, you'll see multiple blue bars, and that's the incidence of how often we diagnose breast cancer in certain races. And you can see that the Caucasian incidence is a little bit higher than the background incidence and in the African American incidence. But again, the African American race, the mortality is just a little bit higher. Part of that, like they touched on, is from less screening opportunities, less healthcare opportunities, a little bit of disparity. We do know that there are some aggressive breast cancers that we do find more often in our younger African American population. We do have lots of events that we bring to some of the more at-risk zip codes in Parkland, and we're always here in case you have any concerns to try and help get you plugged into the system and get you care. Next slide. Nothing can change my risk of breast cancer. That's a myth. Next slide. Although there's certain things that we can't change, like your family history, when you started your period, how late you went through menopause, there are actually several risk factors that you can control. So research has shown that in women or patients in general that have a higher activity rate than baseline, 10 to 20% of breast cancer, or cancers in general, 10 to 20% of them are breast cancers, can actually be lower. So what we advocate is keeping a healthy weight and keeping your overall body fat content down, decreasing alcohol. Breastfeeding is actually protective. So if you are young or if you have young daughters or grandchildren, breastfeeding is something, if they want to do, that can decrease their overall lifetime risk of breast cancer. The most common stat I hear on that is 4% per year that you breastfeed, and that is actually cumulative. So breastfeeding is very good for the child. It is very good for you. If it's something that you're open to doing, then it actually is a very positive thing. Next slide. So please remember to get your screening mammograms if you're in the screening population. We will do everything we can to work with you to get you in. We have several events throughout October and lots of screens that we have opened up. So reach out to your doctors and just remember to get the screening mammograms. Thank you.
So we just want to remind everyone to join us on Saturday from 10 to 12:30 p.m. for another symposium.
Okay, so now we're going to go over some questions that you had. If breast cancer cells multiply so rapidly, is a mammogram a year enough? Is one mammogram a year enough?
I would just say, just from not the mammogram perspective, but it just depends. Cancer cells do divide rapidly, but it just depends on the aggressiveness of the biology of that tumor. Some will multiply much faster than others. So I don't know if Dr. Hayes wants to address the.
Yes, and actually that is a question that we do get asked a lot. So if you have had a formal risk assessment and you are high risk, then we are definitely going to want to screen you a little bit more often. We're going to want to probably do an MRI at 6 months in between the mammogram, so that every 6 months somebody is looking at your breast. But even for average risk women, one concept that's very important to understand is there's only a certain size that we're able to see. So if you have a normal mammogram 1 year, we have got to have a certain change in the mammogram before we're able to actually detect anything. And so screening too often, sometimes we'll miss that window of when it has gotten big enough that we can actually see a change. The important thing to know about mammograms and yearly screening, we cannot stop you from getting breast cancer right now, but we want to catch it at its earliest stage while it is still a very small cancer, and the treatment to take it out is a very small surgery before it is spread. And that is where we have proven the most value with screening mammography, is we are able to catch these cancers even at very small size. Even if it has been a year since your last one, we are still able to catch them at these very small sizes.
Okay. How does exercise reduce breast cancer risk? I can't really join a gym. Is walking okay?
I would say definitely walking's okay. Just staying healthy, and again, decreasing your BMI. Put your BMI at a healthy level. Decreasing, the fat content, which decreases the estrogen levels in your body. It's good for your heart, and it's good for that. Exercise in any form is very good. Wherever, you don't have to go to a gym to do it. You can do things at home. You can walk around the block. You can go up and down your stairs at your apartment or your house. Dancing, Zumba, all different things. You don't have to have an actual gym with gym equipment. You can do lots of different things to stay active.
Right. I get an annual mammogram as a self-referral and get my results in my chart. So I never actually meet or talk to anyone about my breasts. If I have high breast density, who do I talk to about supplemental imaging? Where do I start?
I think right now the best thing to do is to start with your family physician, whoever normally sees you. Right now, supplemental imaging for high density breast still has to be ordered by a physician. So while you can self-refer for a mammogram, you can't self-refer for a screening ultrasound or a screening MRI. So that's going to actually have to come from your physician. When you are at the breast center, you're always welcome to ask your tech, to ask them to look on your last mammogram and what was your breast density, and they can read it off to you. If you are heterogeneously dense or extremely dense, you may qualify for additional screening tools. Now, one thing to understand is just because you qualify for them does not necessarily mean insurance is going to pay for them. It really depends on the insurance company. We'll do our best to work with you, but some women that does become a factor. So I'd say, to answer the question, start with your doctor and see if there's stuff in your family or your density that you need to have a formal risk assessment, and we can get you to the genetic counselors or to the best person.
Okay. Can a pregnant woman develop breast cancer during her pregnancy and breastfeeding her newborn?
Absolutely. Like one of the myths we talked about, unfortunately, that's the most common cancer we diagnose at that time. So if you were at all concerned, talk with your doctor. They will send you in. We have the radiation that we use to do mammograms, the equipment that we use is safe to image you during pregnancy and during breastfeeding. It's a very scary time. So just try your hardest to come in as soon as you can and we will get you through it.
That's it.
All right.
Okay, thank you.
Thanks everybody for coming.
Thank you.